Video case report: peroral endoscopic myotomy in a case with jackhammer esophagus. High resolution manometric guided endoscopic myotomy in a case with jackhammer esophagus. We have no disclosures. These are the keywords. A 35-year-old male was diagnosed with jackhammer esophagus based on clinical symptoms and esophageal manometry. Gastroscopy and barium swallow showed tertiary contractions in esophagus. In this case, we performed esophageal manometry guided peroral endoscopic myotomy. In this case, we preserved gastric sling fibers during peroral endoscopic myotomy to prevent gastroesophageal reflux. After peroral endoscopic myotomy, complete disappearance of spastic contractions was observed. In this video, we demonstrate the technique of manometry guided peroral endoscopic myotomy in a case with jackhammer esophagus. These images revealed barium swallow and the findings of high resolution esophageal manometry. We can see the tertiary contractions on barium swallow, and we can see the length of spastic contractions on high resolution esophageal manometry. The site of mucosal injection was chosen 2 cm above the upper margin of spastic contractions as visualized on high resolution esophageal manometry. A 2 cm long mucosal incision was created using triangular tape knife endocut mode. Subsequently, submucosal tunneling was started, carefully preserving the mucosa. We performed submucosal tunneling using triangular tape knife in spray coagulation mode. Submucosal dissection was performed in the center as well as along the edges to widen the submucosal space. However, intermittently we could see spastic segments. During submucosal tunneling, inadvertent dislodgement of distal attachment was encountered. The distal attachment was carefully removed using rat tooth forceps. Subsequently, the submucosal tunneling was completed. After completion of submucosal tunneling, the myotomy was started. The site of myotomy corresponded to the site of spastic contractions as visible on high resolution esophageal manometry. In the upper part of tunnel, selective circular myotomy was performed using triangular tip knife in same spray coagulation mode. In the lower part of tunnel, a full thickness myotomy was performed. Care was taken at spastic segments where mucosa and muscle were in close proximity. Slow myotomy was performed, and at times the knife was brought from above downward direction to avoid inadvertent injury to the mucosa. A 2 cm long gastric myotomy was performed. The myotomy was preferentially extended towards the right side of the tunnel to preserve sling fibers during myotomy. The preservation of sling fibers was done in order to prevent gastroesophageal reflux disease after peroral endoscopic myotomy. After completion of myotomy, we can see a long tunnel and a long esophageal myotomy being performed. After successful completion of myotomy, we can see there are no spastic contractions visible on endoscopy. Subsequently, the incision was closed using multiple clips. After POEM, high-resolution esophageal manometry showed complete resolution of spastic segments, and the DCI reduced significantly. Barium esophagogram showed disappearance of spastic contractions that were observed before POEM. To conclude, POEM appears to be an effective option in cases with jackhammer esophagus. The selection of the length of myotomy is crucial in these cases. High-resolution esophageal manometry helps in selecting the length of esophageal myotomy in these cases. It is important to secure the distal attachment to avoid inadvertent dislodgement in the spastic tunnel as shown in the video. The preservation of sling fibers may be helpful in avoiding gastroesophageal reflux disease after peroral endoscopic myotomy in these cases.